Talk about this meeting is being recorded. Yes, I will approve that. I'm going to talk about healthcare systems in general, sort of public policy. Some of you guys may know that I'm interested in this topic. I've talked about cost effectiveness before, but today I'll give you a little bit of a broad overview of how healthcare systems are run around the world, with a specific focus on the US and recent reforms, notably the Affordable Care Act today. And I think this is particularly relevant today, given the fact that we're in the middle of a COVID-19 pandemic, and that has demonstrated that healthcare is a finite resource, and it's actually challenged our ability to provide care for everybody. It's also left a lot of people unemployed, and when you're unemployed in this country, that means that you have a tough time having health insurance. So I think it's important for all of us, even though we are specialists, to be aware of the issues that come up with reform and how the tide is sort of moving, so that we can be part of the conversation moving forward. So the outline of my talk is 3 parts. The first part is just how other countries comparable to the US around the world deliver their healthcare to their patients. The second part is a closer look at the US system and some of the issues we face. And the last part, as I mentioned, is a little bit of a zoomed in view of the Affordable Care Act, because it was the biggest reform in healthcare we've had in over 50 years. So the only disclosure I have is not financial, it's more philosophical. I think that we should be moving in this country towards treating healthcare as a right and not a privilege. And in essence, that means that we should be moving towards universal healthcare coverage in this country. And I don't think that that's a very contrarian view. I think most people would agree. I just think that the way that we get there is kind of oftentimes the subject of debate. So this underlying philosophy is going to inform my talk as we move forward. So the first part is the overview of global healthcare models. In 1941, this medical historian, Henry Sigerist, originally a Swiss medical historian, but then took over at Johns Hopkins, when asked about the overarching goals of a healthcare system, he said, it should be a system of health institutions and medical personnel available to all, responsible for the people's health, ready and able to advise and help them in the maintenance of health and in its restoration when prevention has broken down. So with that thought in mind, a basic healthcare system is essentially the exchange between a healthcare provider like us, rendering services to our patients. So this is that 2 parties exchanging goods and services. But because of the complexity of healthcare, we know that you can't do this alone. We actually need a mode of insurance or a mode of financing. And the way in which we set up that financing mechanism is the difference between healthcare systems around the world. So whether it's run by the government or a private insurance, sometimes nonprofit organizations, and oftentimes patients out of pocket will pay for their health insurance. This is sort of how I'm going to introduce what a healthcare model, how they're set up. So there's 4 models. The first one is colloquially called the Beveridge model. It's named after this guy. His name is William Beveridge. He's a English economist and parliamentarian around the time of World War II. And he wrote this very famous report called the Beveridge Report in 1942, which basically outlined a plan for social insurance and was the basis for what Britain then established as the National Health Service. So the Beveridge model is what we refer to when people talk about socialized medicine. And essentially that means that both the providers and the insurance company, the payer, comes from the government. So in the UK, everybody's covered. It's not tied to employment. It doesn't matter if you're young or old or employed or not, disabled or retired, you get coverage, and it's all financed by taxes. Other countries use this model too: Spain, Cuba, South Korea. But this is the Beveridge model is what we mean when someone refers to socialized medicine. The second model is called the Bismarck model. So this is named after Otto von Bismarck, the authoritarian leader of Germany back in the 1800s. So he was credited with creating the first modern welfare state. And one of the things he did was create these sickness funds as a form of healthcare. So in Germany, what people do is contribute to the sickness funds through their employer. And the employer and the employee have some sort of proportion of their income that they pretty much split in half and contribute to the sickness funds. The big difference between Germany and the United States in this matter is that their funds are not for profit. Other countries that use this, France, Japan, and Switzerland, are oftentimes considered some of the best healthcare systems around the world. So this also achieves universal coverage in Germany, because if you lose your job, you actually just remain in the same sickness fund. You have some choice in which one you join, and you never actually lose that, even if you're unemployed. The third model is national health insurance, or what people refer to as single payer. So single payer is different than socialized medicine. Single payer just means that the government usually is the one who provides the insurance, financing, and reimbursement. And so Canada is the most well-known example of a single payer system. It provides universal coverage for everybody in Canada. It's all financed through taxes, usually to the person's province, which is like a state in Canada. It's also not tied to employment, so it doesn't matter what your status is, you're always going to be covered. The Canadian government actually pays private entities, so private hospitals, private doctors, which is a little bit different from socialized medicine. And then the last model, which you could probably argue is not even a model, is out of pocket. So the large proportion of patients in this country and others pay for medical care from their own coffers. This is sort of antiquated. It's what we used to use prior to being an industrialized country, and it's still used in certain undeveloped countries. So the United States is actually considered what we call a patchwork, because there's elements of each one of these four types of models in our healthcare system. So the VA kind of functions like the beverage model, where the government provides the providers and also the insurance. Medicare, on the other hand, is more like Canada. In fact, the word Medicare comes from Canadians, but basically, the government provides this insurance and Medicare pays private providers. The Bismarck model, where you get your insurance through your employer, is dominated by a few conglomerate for-profit health insurance companies in this country. And then, of course, there's a large portion of out-of-pocket expenses by people in the United States. So having said that, we can look a little bit closer into the US system. So healthcare reform has been a debate for over 100 years in this country, from Truman and Roosevelt to Nixon, Clinton, and then Obama. In the 1990s, Walter Cronkite, after his storied broadcast career, was actually involved in a documentary called "What's Ailing Medicine" in the United States. And during that, he said that America's healthcare system is neither healthy, caring, nor a system. So he was pretty harsh on us. And I think some of us instinctively know the reasons why. If you look at public health statistics in the United States, things like life expectancy, compared to comparable countries in Europe and other places around the world, we are constantly lagging in these broad measures of health. So you can see here that the curve for the United States is considerably lower than other countries, and the gap is actually widening with respect to life expectancy. And this covers, all people, men, women, and then of course we have, racial disparities in this country, where African Americans and other minorities do even worse in these large measures of mortality. Same thing with infant mortality. We have a very high rate, 6%. You can see here that the curve is actually widening. Everyone's going down in this measure, but the United States still lags behind other countries. And we have a large percentage of preterm births when compared to other countries with similar GDPs. This is just one more public health statistic, just to kind of drill it into your head, that you could look at an index like the HAQ did, where they look at the 32 most common diseases that are preventable, and they look at all-cause mortality from those 32 diseases and rank all these countries based on that. And the United States falls like way below all these other countries, you can see here. So some of that we know. Other things that we do well, we also kind of inherently know, being specialists ourselves. The more specialized care you look at, the better the US does. So if you look at mortality rate here, for example, from our oncology colleagues, the United States actually does better with preventing deaths from cancer, and has for many years. We also know intuitively, but it's proven that in this country, we produce some of the most high quality and high volume medical and life science research. Our healthcare professionals are trained at some of the best and most well-respected medical schools and training institutions. And we're consistently at the forefront of technology and drug discovery. So that should come as no surprise. But why is there this, disconnect between the public health statistics, the common things being common, and what I just said about what we do well? It just kind of highlights the disparities in this country. If you're unlucky enough to have a complex disease, but you're fortunate enough to have the means, then the US is probably the place where you want to be getting treated. But on the flip side, if you're of lower socioeconomic status and you maybe have a common disease, then this might not be the best country for you. So how can we improve quality when we look at the healthcare system as a whole? So we have to acknowledge, first of all, that health is multifactorial. It's not just access to doctors and healthcare. It has to do with, the culture of the United States, or, how well educated people are, how their pocketbooks are doing, or things like, do they have access to good nutrition? All of these things go into factors that affect somebody's health. But with respect to healthcare systems and their quality, we have to look at certain broad measures and decide, where can we improve? So insurance, I think I've already mentioned this a couple times, but the uninsured rate for people who are non-elderly, so people who don't qualify for Medicare, is 10%, which is about 30 million people in this country. And I'll talk more about that as I go into the ACA part of this talk. So that plays into whether people have access or not to our healthcare system. There's some evidence to show that the United States has the highest medical error rate than anywhere else in the industrialized world. And we also perform procedures at a higher rate than other countries. And as you can see, sometimes that doesn't translate into great outcomes. Distributing care equitably is another principle we should think about. And also the fact that we have this culture in the United States of focusing on treatment rather than prevention. So that comes from the fact that we're very good at, studying disease, figuring out what the cause of that disease is, and then finding a treatment for it. That's very different than thinking about preventing health and maintaining health. Like that quote at the beginning of my talk said, stepping in when health breaks down, but really focusing on the maintenance of health and prevention. So the ideal elements of a functional healthcare system, I'll kind of go through this a little quickly because I've already mentioned some of it, but essentially you start with access to care. That's both financial and non-financial. The financial aspects really has to do with, can you afford health insurance, or is there some subsidy from the government provided for you to be able to have insurance? And then there's non-financial barriers as well. So is there a doctor in my town? Is there a specialist in my town? Can I get to the hospital? Can I, make a timely appointment? Can I navigate the online EMR to get my medical records? All these things have to do with access and are non-financial. Assuming you have access to care, then we have to have our healthcare providers have adequate scientific knowledge. So I'd say we do a pretty good job of this in the United States. Everyone has switched to this mode of trying to practice using evidence-based guidelines and using translational research to, translate things from the bench to the bedside. Um, so if a patient has access, if they visit a doctor with adequate scientific knowledge, you better hope that that provider is also competent. So, you know, I already mentioned we train some of the best doctors in the world, but we have to continue to, you know, test those doctors when they're out in practice using certain performance measures, which are usually based off of this evidence-based practice. We also have board certification and continued medical education. And when someone's not doing so hot, we have methods in order to remove bad apples out in the community. Finally, if you visit a competent doctor, you better hope that they're making a decision on your care based on what we call, you know, shared decision making, or listening to the patient's wishes, rather than having some sort of financial incentive to treat or to undertreat or to overtreat. And I talked about eliminating waste as well. But these are all elements that we have to think about when we're looking at the quality of our system and where to make reform. Of course, the system itself and how it's organized is very important. So right now, things are very fragmented. You know, we have HMO networks and people going to different hospitals where the EMRs don't talk to each other. This is another area of improvement. So these are the types of things with quality that we have to consider. Switching gears a little bit, let's talk about cost for a minute before I move on to the final part of my talk. So I think I've said this in a previous Grand Rounds talk, but just to highlight the point that the United States spends more than other comparable countries on healthcare, about 18% of GDP in 2019. That's compared to about, you know, 10, 11, 12%. It's kind of the norm in these other countries that I've already mentioned. And the cost is rising at a rate of about 4.5% or more over the past few years, and that's been pretty steady. And as some of you may know, the whole entire economy does not grow at this rate. So at this rate, the healthcare costs are outpacing our economy. If you look at the breakdown of where this money goes, not surprisingly, inpatient and outpatient care is a large chunk of it. But really what this is trying to show you is what are the proportions of the money we use and where do they go? And the big differences here are, you know, the United States spends a bigger chunk of its money on prescription drugs and medical goods. And also this administrative trunk, which doesn't even really relate to patient care, is a big source of sort of medical waste, you could say, compared to other countries. Other countries also spend more on things like long-term care, which is becoming a bigger problem in the US as the population ages. So if you look very quickly at how the expenditure breaks down, not surprisingly, about 3/4 of the money spent in the US goes to health insurance. And if you look at where people are getting their health insurance, about 1/3 of people have private health insurance, which I think is rather surprising. You'd think it might be more. But about 2/3 of people are getting some sort of public financed healthcare insurance like Medicare or Medicaid. There's also this large chunk of out-of-pocket. 11% of expenses come from the patients themselves, which is rather large. So if we're going to control costs, we have to think about what's the best way to do that. And this very simple economic curve kind of helped me understand what the goal is. So if you look at healthcare costs versus outcomes, it's kind of this curve here that starts out very steep and then flattens, meaning, when you initially put money into the healthcare system, it's for a rather cheap cost, you can get a good outcome. Things like vaccination programs or smoking cessation programs, things that don't cost very much, preventative care, but can give you a lot of bang for your buck. Not surprisingly, will get you higher on this curve. But the United States is pretty much on this flat part of the curve where new technologies come out and we spend a great deal more money, but we're not really getting all that much out of it. So the idea is not really to go from point A to point B anymore. What people are trying to do to control costs is instead kind of move up to this point C. And if it basically means that you spend the same amount of money, but get a better outcome, and that's called kind of shifting the curve. So when you think about cost containment, this is what we're essentially trying to do, or just get more out of the money that we already spend. So there are different methods for cost control, and you'll come across these as we talk about reform, or just talk, about our system in general. But on the financing side, you can try to limit how much money goes into the healthcare system. If you do that, basically that limits the output. So you can put the government can put regulatory limits on taxes or premiums. You can introduce things like competition between insurance companies and make people more cost conscious with respect to choosing their healthcare program. But if you do that on one side, it's a balance, right? So you actually have to look at the reimbursement side as well. So what folks are trying to do is look at the fees paid to providers like us, the price of pharmaceuticals. There's this, aggregation of payments, which I'm going to talk about a little bit more on the next slide because I think it's important to understand. And then other ways of cost controls are shifting costs to patients, which is, as we can see, is pretty difficult on people. Things like utilization management, where insurance companies or hospitals kind of question your practice methods to see if they're actually needed, or if you can get a patient out of the hospital. These types of things are all about cost control, and cost effectiveness analysis as well look at value in new and more expensive treatments and strategies, and decides whether or not they're giving you enough effectiveness to adopt. So just to hit on this point a little bit more, because this is a huge shift in tide in our current healthcare system, is how the reimbursement spectrum is shifting from kind of the left side here, which is the fee-for-service model, to more what we call aggregated payments. So, prior to the 1970s, doctors and insurance companies would pretty much just adhere to the fee-for-service model. And that meant that, if you're a doctor, you could order whatever tests you want and get paid for it, which is great for some reasons, but for other reasons, it sort of encouraged over treatment, right? And things were going well prior to the 1970s. The economy was running hot, and people didn't really pay much attention to healthcare costs at that time. As things started to become, a little bit more difficult economic-wise, things like per diem, where a patient is paid per day they're in the hospital a set amount, or the fee per episode, the DRG, which is used by Medicare now, where the Medicare will pay the hospital a flat amount based on their main diagnosis, has come in more popular. There's things like capitation, where you can have a list of patients on your insurance roll as a provider, and you're paid a certain amount per patient, no matter if they come in to see you or not. That's commonly used in the UK, especially. And then things like global budgeting, like hospitals may get an annual budget and have to stay within that budget, or have to underwrite the costs. So if you think about this, spectrum, there's good things and bad things about both sides. On this side, I think we already mentioned that it sort of encourages over-treatment. Well, on the other side, if you're trying to stay within a global budget, then you are risking under-treating your patients. The other way to think about it is, where is the risk, the financial risk? On this side, the entire financial risk is to the payer, insurance company. The doctor doesn't, see any risk if the patient gets sicker, because he can just order more tests. On the other side, this is sort of shifting the financial risk to the providers. So there's been some move from the left, which was heavily relied upon, to more balance of these different types of payments, which we need to be aware of. Okay, so the last part of my talk is more about the ACA. So I'm going to give myself a little break from talking. I don't know if this is going to work. I don't see a play button. But this is supposed to be Mitt Romney in 2012 talking about the ACA, and when he was asked about uninsured people, this is what he said, and I'm not sure this is going to work. Let's see. Doesn't look like it's going to work. That's a bummer. Okay, anyways, I kind of put that in there because I remember, he was on 60 Minutes. He basically said, we do treat uninsured people. When they get a heart attack, we come pick them up, we put them in an ambulance, and we treat them. So The reason why I put that up there is because this is, this is a presidential candidate, and admittedly somebody who actually instituted universal healthcare in Massachusetts before he ran for president, sort of laying out a common misconception about what an efficient healthcare system should do. It shouldn't be one that treats people when they're already sick. It should be one that sort of focuses on somebody and preventing disease. So I kind of placed that in there to give myself a break, but it didn't work. So this last part is about the Affordable Care Act. This is a long paragraph from Barack Obama in his op-ed in 2016, but he basically said healthcare costs affect the economy, the budget, federal budget, and virtually every American's financial well-being. Health insurance enables children to excel at schools, adults to work more productively, and Americans of all ages to live longer, healthier lives. When I took office, healthcare costs had risen rapidly for decades. Tens of millions of Americans were uninsured. And regardless of the political difficulties, I concluded comprehensive reform was necessary. So this was at the time when insurance companies were practicing a little bit more nefariously, and we had a really high rate of uninsured people in 2010. And so what the ACA tried to do was, first of all, to expand coverage. So the way that it did that was, number one, it expanded Medicaid, expanded the definition of someone who's low income and who would qualify for Medicaid. And then it provided federal aid to states who adopt the expansion. At this time, there's no mandate for states to adopt it, and about 12 states, I believe, have still held out. The other way that the ACA tried to expand coverage was by setting up these insurance exchange, which I think we're all familiar with. But states basically will show people premiums and what's covered to try to increase this notion of competition, to try to make people more cost conscious, and to try to fill the gap in people that are not, getting plans under their employment, but also who do not qualify for Medicare and Medicaid. So people get subsidies based on their income level, and all employers who have 50 or more employees have to provide some sort of healthcare plan. So we know about those of us with kids know about the 26-year-old rule. Our kids can be on the parents' plan until they're 26 years old. And really importantly, Obamacare ACA did not provide a not-for-profit public option, although that was thrown around in negotiations when it was being written. And it sort of forced the hand of the private insurance companies to make some concessions in order to not include this public option. So how did the ACA do with respect to insurance? Well, if you look at trends of uninsured Americans over the last 60 years or so, you can see that there's two major drops in the amount of uninsured. One came in 1965 with the passing of Medicare and Medicaid, and the only other significant drop was here around 2014 when major provisions of the ACA took effect. So this is just a zoomed in view of the past 10 years. Right at the beginning of the passing of the ACA, we were at close to 18% of uninsured people who are non-elderly, meaning they didn't qualify for Medicare, which equated to about 50 million people. In 2014, you can see there's a precipitous drop here to about 10%. So that's still 30 million Americans, but this gap here that was closed was about 20 million people either received insurance through Medicaid or through the insurance exchanges. The past 3 years is the first time in the past 10 that we've actually gone up in the number of uninsured people. And that has to do with, the slight changes of, repealing the individual mandate or the tax that people have to buy insurance. But this, has changed only slightly over the past few years, which some people point as evidence that the ACA is here to stay. I talked about insurance regulation, so guaranteed issue, meaning that it eliminated the insurance company's ability to deny you for pre-existing conditions, which is very important, especially when you couple that with the individual mandate, meaning that people have to buy insurance or suffer a tax. So when you do that, you actually increase the risk pool for insurance companies to include more healthier people in order to cover the sicker people. So it's very important those two things went together. It also outlawed a practice called rescission, which is essentially when the insurance company would cut off your insurance after you got sick. These annual and lifetime limits on reimbursement was also causing people to drain their savings account, because if they had chronic diseases and they reached their annual or lifetime limit, then the insurance company would no longer pay. And so people had to drain their savings account until they qualified for Medicare or Medicaid, and that was the common thing before the ACA. It also tried to limit administrative costs by 20% or less for each of these companies. How was it paid for? Well, there were new taxes, some on drug companies, medical device makers, and health insurance companies. It also raised the Medicare tax on wealthier individuals, those making 200 grand or more, and expanded this to people who make their money off of investments. The individual mandate taxes and fees provided some financing, and so did taxing employers who didn't offer plans to their employees. It tried to implement some cost controls, things like Medicare reimbursement being tied to this more value-based payment or pay per performance. And it introduced a fraud detection program to try to eliminate financial waste and fraud. And as I mentioned before, it tried to increase competition by using the marketplaces. There's some other ancillary, the bill is very large, but other ancillary things that it did was it required calorie counts to be displayed by chain restaurants, and also encouraged medical students to go into primary care by taking care of some of their debt and reimbursing primary care physicians for seeing Medicaid patients. So if you Google ACA and otolaryngology, you're going to find maybe a dozen or so articles, and most of them have to do with head and neck cancer. So I just put these 4 up here because they're all pretty similar in the methods that they looked at to see what the ACA has done over the past 10 years. So these 4 different groups either looked at SEER or they looked at the National Cancer Database, and they examined the time prior to the ACA versus the time after, and also examined states that expanded Medicare or Medicaid and states that did not. And they compared things like staging, for which a number of these papers actually found that there's evidence that folks are presenting at an earlier stage in their cancer. They also looked at insurance rates, which by no surprise went up in the states that expanded Medicaid and were different than those that didn't. And it also, like this paper over here by Dr. Weisbrod in San Diego looked at whether patients for early glottic cancer, what kind of treatment are they getting? And they actually found that there's a trend towards more surgery rather than radiation. So I thought that it was interesting that if you look at, there is some evidence that both practices are changing, and also the nature of the patients we are seeing might be changing, hopefully for the better. Okay, so that's pretty much what I had for today. Just to remind you guys what I kind of talked about was I started with the 4 models of healthcare and how the US system is a patchwork. And then the third part of my talk, I talked about the ACA and how it's done pretty much with respect to insurance. And it's not, it's not perfect, but it at least was a start. So looking towards the future, I hope that at least this talk has given some people some knowledge of the basics of what issues are being discussed, mostly because we hear about this stuff, but it's really important to be educated so that we can be involved in discussing how things are moving going forward. This is new journal by JAMA. It's called JAMA Health Forum. You can look it up. It's actually really great if you're interested in just doing some quick high yield reading about current issues. And they're going to be accepting original research too, starting this year. So that's, if anybody has any research ideas about things that I discussed, and I'd love to talk about it. So these are some references, and of course I'm going to put up some pictures of my little baby, and I will take any questions if there are any.
Joe, thank you for a talk to, highlight sort of a perspective for people, as, sometimes we don't obviously appreciate all these things. And I'll just preface by saying I'm not only cynical, but I'm also contrarian myself. So I'm going to take any position that's going to, try to challenge someone. Obviously, sleep surgery is sort of a tiny area and sort of controversial as to whether it should exist really at all. I mean, obviously, some people, we may feel otherwise, but across the medicine, people may feel that it's not really a good use of resources, whatever you want to say. But I certainly know in my field some, I don't know, I would say egregious examples of things that are not working in many other countries. And I'm not just talking about access. I'm talking about, Canada, it's like impossible to get anything done in sleep surgery, not just because there aren't that many sleep surgeons, but because, there's this incredible limitations on, the problem isn't, we don't want to make everything set up so the surgeons are happy. But we want to obviously take care of patients, and access is important. But access to operating rooms for procedures, including many other fields that we would argue are clearly compelling to preservation and maintenance of life, quality of life, if not length of life, are real limitations. And so you can't get things done. I mean, the provinces will shut down for prolonged periods of time for anything except urgent or emergent cases, sort of like the pandemic situation. Now, Canada does many things right, but they do some things wrong. And Europe, you get a sleep surgery in Germany, you stay in hospital 7 days because that's how the incentives are structured. Germany, you think of pretty wise, traditionally we think of it, the good, they build good cars maybe, but, and, all these things that they would have things sorted out. But 7 days in the hospital, it's a little bit absurd. And there are pros and cons of that, but there are definitely cons. In Holland, every single person with snoring, it's like standard of care pretty much to get sleep endoscopy, which I think is just an outrageous waste of resources. And so my question for you, as someone who's been interested in these topics for a long time, I'm always thoughtful about what countries do you think have it right? And I think Singapore, they have a lot more cost sharing, which I think sometimes, and for people based on means testing, and I think that they do things a little bit, a lot better in many ways, basically caring for people that don't have means in a totally different way. Of course, Singapore is a complete fluke in terms of, they have this city state that doesn't really, not going to necessarily be scalable and applicable to the United States. But I think there's some tough decisions we have to make about rationing of care, which of course, things, and certainly rationing surgical care, which I think is probably appropriate. Doctors are as guilty as anyone of finding the system and responding to things that are, compensation incentives, and fee for service, of course, is not. It has some very different incentives from some sort of centralized approach. But what countries have you thought have really done a good job? And is it something we're going to chart our own path, the typical American way, or is it something that is going to be where we can find some examples that are working really pretty well?
Well, thank you for that comment. It's absolutely appropriate to, point out the pros and cons of all of the countries I mentioned. And I didn't really go into detail about the things that people say are good about those countries and the things that you mentioned that are complaints. And I think rather than asking the question, which country does it right, it's what aspect of all of these different models do we want to borrow, and do we want to integrate into the US system? Because we know what problems we have. You just pointed out a bunch of them, but we also know what we do well, and we don't want to change that. So what I would say is, absolutely, rationing care, we don't want to move to the point where, in some respects you said we do, but really the rationing of care that in the US is the most pressing is really the amount of dollars we have. This is where we're kind of running up to the point where we can't really go too much higher. But as far as like number of doctors and number of procedures, we're actually doing quite well. The only thing I can think of in the recent history that has challenged our rationing of medical care is the COVID pandemic. Number of ICU beds, number of doctors, et cetera. So, I'm going in the weeds here a little bit, But it's not that we should just look at Canada and say, let's change and try to be exactly like Canada. It's more like what problems do we have and how can we fix them in the most painless way, without affecting the things that we do well. And you know, a healthcare system is never going to be perfect. It's like trying to achieve perfect health. Nobody's going to be able to do that. But it's this equilibrium that we keep shifting back and forth, and you kind of have to choose the things that you think that you want to focus on to improve, while at the same time acknowledging that those things that you improve might bring up new issues. So I hope that sort of answers your question. I think my point was, you know, in this talk really was the insurance issue is one like low hanging fruit thing that you could focus on and say, well, if we can, you know, make this better than you know, keeping in mind quality and cost, I think we can, you know, make our public health a lot better. But
I think if I may, I was in Korea last summer and I actually saw kind of hybrid model working pretty well, but at the same time point out at some of the difficulties they're experiencing. I think they have a single payer system like Canada, but they have a mixed model where they have a lot of presence of private insurance company. Because I think the nationalized healthcare system, they only cover up to 60% of the total cost. That's outside of primary care. The primary care is pretty much free. But in addition to that, if you're getting a complicated surgery, procedures, I think the hospital bill still comes up to just cover 60%. They recently passed a bill. They have a very progressive government now. They cover, I think, up to 90% of all the cancer treatment. So that was a big move. But at the same time, they're suffering from their budget kind of shortage. They used to tax a lot of industry that's bad for public health. Tobacco industry was huge. Korea still has a developing country, has the highest smoking rate, and they're taxed. A lot of their income came from the tobacco company, and now they're kind of decline. I think as a country, they're kind of coming into this budget problem. As a result, I think a lot of they allow private insurance to subsidize their bill, so that's a very big thing in Korea. So when I rotated there, like Dr. Kazir mentioned, patient get tonsillectomy, they stay for 3 days. Septoplasty, they stay for 3-4 days. I think that's based on the old model of the system. But they also encourage kind of their citizens to, if they have means to afford, they have that expensive private insurance to subsidize. And they do a lot of scarless robotic surgery. I remember just listening to consultation. If you're just getting standard neck dissection, radical tonsillectomy, you'll be staying with us for 14 days, flap, or you can do, if you pay, you know, copay will be another $9,000 if you want to do scarless neck dissection robotic surgery. And depending on the socioeconomic status of the patient, they decide to take the, you know, what's offered as a standard or slightly behind, or whatever that maximize the old model, the compensation for doctors, wherever the balance is, versus, you know, if they have a means to pay for it, they have an option to do so. That also kind of accentuated kind of, you know, the ones who are wealthy and, you know, who's not, they definitely accentuate the care they receive. I think the relative depravity of this demographic who are not wealthy, it definitely, I could see that there's a discrepancy of how they're treated, or they, you know, even I could see that in how they feel they're treated. So definitely there was a good part of that of what I've seen, but there's definitely part that I saw, you know, this is probably not fair. But yeah, I don't think there's a perfect system.
Yeah, I mean, you bring up a great point. You know, there still is a role for private insurance, even in these companies or in these nations that I mentioned, in the UK and Germany and Canada. There is like a 10% percentage of people who still have private insurance, which sort of lets them get certain perks. They can cut the line, they can get a private healthcare, they can get a private room, things like that. And I think that there's a market for that, and it's not necessarily bad, because you know, if you strive for complete equity, it's another ideal that's very difficult to attain. But the thing is, what you mentioned is that the government at least provides a basic package of healthcare insurance, and how extensive that basic package is sort of up to both the government in conversations with folks like us who have the knowledge of what is, cost effective and what is important versus, what is waste. So this is an ongoing thing that I think that we need to have our input on in order to make sure that if we do offer, a public basic package, that it includes things that that we believe are necessary for people's well-being.
Hey, Joe, great talk. I have two questions. So one is we hear a lot about, or we used to hear a lot about the single payer system, and maybe that would, Medicare for all, maybe that would eliminate the 20% markup that insurance charges, which I think is the percentage that you quoted. I don't know if you have an opinion on that. The pluses and minuses, I guess, would be the first question. The second question is, for the picture on the left, is that avocados on the dress?
That is avocados.
Okay.
As you may or may not know, if you look at my last name, it has similar letters to avocado. And so we bought that dress on purpose. But in answer to your first question, yeah, I mean, switching completely to single payer like Canada, or saying Medicare for all, that's a pretty radical change. And it won't, if you did that, I imagine that it would force private insurance companies to sort of rethink what they're charging, and it wouldn't totally eliminate them, but it could possibly sort of either make them more cost conscious or even push them out a little bit. And there's going to be a lot of pushback with a big change like that. So the other option is that you can, make a public option, but have it be optional. So it could be on the insurance market where, you could buy Blue Cross for X amount of money, you could buy, Medicare for X amount of money. That's another way of doing things. And then, the most radical thing you could do would just be to blow the whole thing up and make it like the UK, which I don't think is, very practical. But yeah, that's, if you look at the candidates for president this year, I think a large number of them said, let's do Medicare for all. Some of them said Medicare for all who want it, which is like not mandatory. And then, Bernie Sanders, I think, said, let's just do single payer or something like that. So yeah, I think I'm a realist. I think we need to build on what we've done and not, like Dr. Kazarian said, if you introduce something fully new, then there's a lot of problems with it. So we have to sort of build on what we already have and keep what we've got, the good things we've got going.
I want one more thing. So, I mean, Bernie Sanders couldn't find his way to her bag. That guy, I mean, he says things that has no clue about how to accomplish things. So that's just my opinion, of course, but it was seen on debates. But the point is that for people to go to any sort of, I mean, Oregon has something much closer to a potential. I mean, obviously Oregon's a pretty left-leaning state, but they've made some decisions where they cover, they sort of draw the line, and they cover things below the line and they don't cover things above the line in terms of, value. I guess they make some decisions. And apparently people, have they've accepted some of this, and it's the public option, of course, and there's private insurers that don't abide by that. But I think for anything like a move to a single payer or a real public option, so many advantages, there's going to be a need for people to accept some sort of care rationing, which probably is really good. I mean, Medicare fraud is, billions of dollars every year. Doctors are as guilty as anyone of taking advantage of the system, or I shouldn't say as guilty as anyone, but they've definitely been guilty, and healthcare networks have been guilty of taking advantage of the system a little bit too much free for all. But the point is that, I mean, my colleagues in other countries like Korea, other countries as well, doctors see 80 patients in a day, and I'm like the least efficient with my time with patients, but I can't see 80 patients a day to provide the same care that I think my patients sort of expect, and you might say demand. And that's, maybe good, maybe bad, but the point is that is there any research, whether it's in Oregon or anywhere else, that people have a real awareness of what rationing of care might be involved with a major transformation of the healthcare system, and that there's a greater willingness to accept that with, something, basically accept that I'll accept shorter care visits, waits for surgeries so that other people can actually see a doctor instead of, waiting till they're in disaster mode and have to go to an ER.
I think there's like the public in general, that's like one of the things that they have the biggest problem with, right? The word rationing scares the average person. And sometimes they don't understand what that means, but I get what you're saying. There's always gonna be some sort of limit that you have to put on what you're going to cover. And that doesn't matter if it's government run or private run. But I think there's a painless way to do that, and I think there's a painful way to do that. And the painful way is that we get rid of, helpful patient interventions in the name of saving cost, without looking at the things that are really just medical waste that we could eliminate without affecting patient care, like administrative costs, or like you said, unnecessary procedures, doing unnecessary imaging, et cetera. So there's a lot of wiggle room first, in order to sort of stay on that part of the curve that I talked about, where you're increasing efficiency without affecting the financing. But you're absolutely right. I mean, when you talk about rationing, it really, it's something that makes people averse to any change. But I think there's some already form of rationing that exists in our system. We just don't really recognize it as rationing. Not everybody gets every possibly beneficial treatment that's available. It's just not, they just don't. So I think we sort of need to educate and think about it very carefully before we introduce some sort of basic plan like you mentioned.
I mean, you're absolutely right. We have the wrong kind of rationing going on now. The question is whether we can do it better, and whether the people that are not having their care rationed now will accept some rationing for the greater good.
I don't think we're ever going to achieve that greater good, though, until we accept your first slide, which is universal health care, or care for all is a universal right, as opposed to having an AR-15 is a universal right. So I think we as a country need a major shift in our thought process before we're ever going to achieve this. And I think, we also have to realize that, there is, to achieve healthcare for all, everybody's going to take a hit on this. If you look at the cost of healthcare, what does Congress go after? They go after the doctors because it's easy. We don't fight back, so they start cutting reimbursement. We're probably one of the few, if only, professions that will accept pay cuts over time, and it's inevitable. Your guys's, as a residents, your earning capacity is going to be far less than mine, which is far less than, my mentors, who were in the glory days of medicine in the fee for service days. So, everybody's going to take a hit in this, and it's going to include patients and doctors and insurance companies if we're ever going to achieve a more, universal healthcare system.
Yeah, you're absolutely right. And I'm not sure I can quote an exact number, but I think if you, surveyed the public, most people do kind of agree with the universal healthcare coverage in some form or fashion. If you just ask them, is that something that you want? And the reason why cost containment commonly goes after providers is because of this slide. I mean, where you see where this huge chunk of our where we spend money is in the inpatient outpatient setting, and so they see this as the biggest opportunity in order to cut costs, even if it may not be appropriate.
But Joe, does that include the hospital costs? Because that's a huge chunk.
I mean, I'll have to look at this. Is just inpatient and outpatient. I think it does. Yeah, I think it does.
Yeah.
But
because the doctors are a fraction of what the hospitals make.
Yeah.
And the hospitals are making the big money. Yes, there are doctors making. We do make a good chunk of that money, but the hospital costs are huge, we're an easy target.
Yeah, and this is the reason why doctors are now aggregating together into these big practice groups, is because there's strength in numbers. There's the easier ability to negotiate for your fees, the larger that's your, you know, the more people you have on your team. And so there was a shift in the 90s where, you know, the providers were really taking the hit. And then there's kind of been a comeback with a decrease in popularity of HMOs and more, you know, PPOs and other forms where providers are doing a little bit better now, but it's because they're all kind of conglomerating together so that they have more bargaining power. But that's a good point.
Yeah, when I was in Korea, actually, one thing that I noticed that all the doctors there hate the government. They're very vocal about it. And they're counting every single surgery cell they're using in the OR because they have to record every single thing they use, needles, and pretty eye-opening.
You know who else does that though? Is surgery centers. And when you are paying, when a patient is paying a lump sum for a procedure, you start managing what you're using, and you get every last little bit out of a suture so that you're not spending extra money, and that goes to you. Yeah. So it's, you know, there is certainly room for cleaning up the waste in our system. And that it just matters what your pressures are.
All right. Well, I think my hour is up, but I really appreciate the conversation, and you know, look forward to talking about this more in the future.
You know, I live through universal system in Poland, so I'm very happy off the screen to discuss this with you, because we need another hour at least. Okay,
Yes,
it does not work. It creates corruption. It creates opportunities for doing really not good medicine, and people don't really have. If you're really sick, you're not going to have appropriate care. You have to know people. You have to know where to go. It's not working, and somebody has to pay for it. And as Dr. Kokot said, we are the easiest target. We do not fight. So we are the one who will be taxed more. We are the one who will be reimbursed less, because the richest, they can afford fantastic lawyers. So they can get out of the taxes, even if they should be paying the big share of it. But this is for another hour at least. So we can talk off the screen.
Good. Okay. Sounds good. Thank you guys. Appreciate it.
Thanks, Joe. Just don't take my AR-15.
Never. I don't have any use for it.
Are we ready to dive right into the second year presentations?
Sure. They were probably hoping for that extra hour of discussion.
Okay, I'm gonna go first. I'm gonna share my screen. Kim, I don't think I can share my screen yet.
Well, wait, Joe needs to, here, I'll kick Joe off.
Still sharing?
Wait, yeah, Joe, if you just want to step, there you go, perfect. Now you should be able to. Perfect.
Okay, everyone see this?
Looks good.
Yes.
Okay, so I'm Allison Yu, and I will be presenting my second year presentation on parathyroid adenoma. It's not letting me